Thank you very much for this very nice introduction. Thank you very much to the organizers also for giving me a call for another keynote lecture. And I would like to present one lecture about a new drug in the treatment of pulmonary arterial hypertension. This is a fixed dose combination of Macitentan and tadalafil. And we're going to start. So just a little bit of background. I'm going to talk about the pulmonary arterial hypertension as a medical doctor. It is uncommon, progressive, and life-threatening blood vessel disorder differentiated by the constriction of minor pulmonary arteries and elevated blood pressure in the pulmonary circulation that in the end leads to the right heart failure. And the symptoms are well known. These are breathlessness and fatigue in the first account. And patients with pulmonary arterial hypertension do have an abnormally high blood pressure in the arteries of the lungs. Therefore, it is very important to keep our patient informed about pulmonary arterial hypertension and what does it do. And at the beginning, I would like to give you a few slides, just a few slides about the possible about the patient education, because the better patient education, the better compliance in everyday prescribing of drugs. I have 3 websites chosen for this opportunity. The American Lung Association, very nice informative website for the patients with pulmonary arterial hypertension. For example, there are very important data like the pulmonary arterial hypertension is most common in women between ages 30 to 60. There is no cure, but the treatments are available to control the symptoms. And of course, it's a really uncommon illness. You can see that only about 500 to 1,000 people are newly diagnosed with pulmonary arterial hypertension. The second one, very nice, Pulmonary Arterial Association of United Kingdom, very nice website for our patients. Again, I'm stressing out more the education equals more the compliance in everyday practice. And the third one, quite friendly, also, it's the Australian Health Direct website. This is a free Australian health advice for each and every patient. And I think that the educational process can be quite nicely done with this website, offering very useful information for patients with pulmonary arterial hypertension. If we go back to the core medicine, we can say that we have 5 groups of pulmonary hypertension by the World Health Organization, starting with group 1, which is idiopathic, heritable, associated with drugs and so forth. The second group is due to the left heart disease. The third group is due to the lung disease or hypoxia. The fourth group of pulmonary hypertension is usually a consequence of pulmonary arterial obstructions. And the group 5 is also very important, but maybe the hardest to treat because many times we have unclear or multifactorial mechanisms involved. So this classification is presented by underlying pathophysiology, hemodynamic characteristics, and clinical presentation. Moving forward, we can see that the symptomatology is having also the classification in 4 classes, and it is also done by the World Health Organization after the New York Heart Association Heart Association classification used for heart failure patient, and it is a strong predictor of survival and disease progression. We can see that the functional classification showed us that in the first group we don't have any limitation in physical activity. In the second group, there is a slight limitation. Third group, marked limitation. And the fourth group of the functional status is characterized by unable to carry out any physical activity without symptoms. And usually we are using these tests, like ordinary physical activity does not cause undue dyspnea or fatigue, chest pain or near syncope, and so on and so forth. So this is the classification, functional classification according to functional status. And this is very important to follow the further drug treatment options. Only in 10% of patients, the very old approach of giving the calcium channel blockers works, actually. But in over 90% of patients, we need to start with the adequate targeted therapy for treatment of pulmonary arterial hypertension. We have several drugs, a group of drugs, drugs targeting the prostacyclin pathway, targeting the endothelin pathway, drugs targeting the nitric oxide pathway, the activin pathway, and the combination product Macitentan with tadalafil, which is going to be presented today. So we can see that in the first group, targeting the prostacyclin pathway, we have drugs that are administered by the intravenous infusion, but the last one, treprostinil or selexipag, are orally administered drugs. Drugs targeting the endothelin pathway are very interesting for us today because we are going to talk about the Macitentan, which is non-selective endothelin receptor blocker. Afterwards, we are going to talk about the tadalafil, which is a drug targeting the nitric oxide pathway, and it is a phosphodiesterase 5 inhibitor. Also, we have in this group soluble guanylate cyclase stimulator. Drugs targeting the activin pathway, this is sotatercept, and this is also a new drug. And now we're going to start with the Macitentan tadalafil. Why do we need the new drugs? Why do we start our investigation? Preclinical first and then clinical. Because of this, we want to have our drugs to have adequate efficacy, but most of all, the adequate safety. But you can see all those groups are having specific adverse drug reactions relations. And for example, drug targeting the prostacyclin pathway, flushing tachycardia, hypertension, and so forth. And the last one, which is going to be applied through the inhalation, has also throat irritation and cough. Please remember that with the inhalation products, you always have to tell your patients just to rinse the oral cavity after using the inhalation products, especially, for example, if you are prescribing inhaled glucocorticoids. This is very important notion. Drugs targeting the endothelin pathway, anemia, edema, nasopharyngitis, hepatotoxicity, teratogenicity. We are going to talk about it a little bit later in full detail. Drugs targeting the nitric oxide pathway. These drugs are primarily targeted for the erectile dysfunction. However, preclinical and clinical investigations that are going to show you showed us the potential of using these drugs in treatment of pulmonary arterial hypertension, although tadalafil is having a classical unwanted effects like headache, flushing, dizziness, hypertension, and visual changes. And there is a sotatercept. It's quite another story with adverse drug reactions. So the aims are very clear and simple. I'm a pharmacologist, so I do pharmacology. The main objectives of this presentation will be to clarify the pharmacological properties of this fixed dose combination of macitentan, tadalafil. Clinical development, we're going to talk about pharmacodynamics, pharmacokinetics, indications, contraindications, adverse drug reactions, and drug interactions. Very interesting. So this is the basis. This is something that you can find on the FDA website or on the website of the manufacturer. So macitentan tadalafil is a combination of macitentan endothelin receptor antagonist and tadalafil, phosphodiesterase 5 inhibitor, indicated for chronic treatment of pulmonary arterial hypertension, but only group 1, so the lightest group of patients, in adults patients in World Health Organization functional class 2 to 3. What is important that clinical trials showed us that individually macitentan reduces the risk of clinical worsening and worsening events and hospitalization, while tadalafil improves exercise ability. We can see that on the market we have two combinations, 10 over 20 milligrams and 10 over 40 milligrams tablet taken orally once daily, with or without food. As a pharmacologist, I would like to, stress out that this is a very friendly, for our patients, that they can use only one tablet, fixed dose combination, and they don't have to think about the food. So the FDA approval of this drug is based on the results from the pivotal phase 3 ADU study, and I will show it the main results, in which this combination demonstrated greater reduction in pulmonary vascular resistance after 16 weeks versus tadalafil or macitentan monotherapy, which means that with this approval, a pulmonary arterial hypertension portfolio was, successful and offered this very nice combination. However, because of the known macitentan unwanted effect, this combination has a boxed warning due to the risk of embryo and fetal toxicity, and requires female patients to enroll in the macitentan containing products risk evaluation and mitigation strategy. What is risk evaluation and mitigation strategy? So we can see that although we were having results that were really, unexpected maybe, the newest FDA approval, the newest FDA alert issued on April the 2nd this year, released all the drugs that are containing tadalafil from the macitentan containing products, this mitigation program, and this was based on evaluation of human fetal outcomes reports from 2001 to 2024. However, some things remained. So based on the animal data, these drugs may cause fetal harm or if used in pregnancy. So females of reproductive potential should not be pregnant before the study, during the study, or 1 month after the study. And when pregnancy is detected, we need to discontinue the drug and follow the patient to see what will happen, because many drugs that are initially not prescribed, not approved to be used in the pregnancy, but the study subject remain pregnant, we follow complete pregnancy, and after the childbirth also what is going on, if something is going on. Let's go to the clinical trial. Very simple, elegant, and efficient clinical trial. So the background was that endothelin receptor antagonist and phosphodiesterase 5 inhibitors combination therapy is recommended for the treatment of pulmonary arterial hypertension. And in this study, the authors wanted to see if once daily single tablet would simplify treatment over the separate treatment of initial components. And this was the multi-center, double-blind, adaptive phase 3A2 study, investigated the efficacy and safety of macitentan tadalafil combination, vice macitentan, or tadalafil as monotherapies. And the screening was very simple, using the inclusion and exclusion criteria. We obtained the 3 final groups, one with patients treated with macitentan, whether they were treatment naive or they were receiving some of the endothelin receptor antagonist. On the opposite side, it is the same for the tadalafil, and in the middle you can see the group of patients having fixed dose combination in their protocol. And the result, the primary endpoint was change in pulmonary vascular resistance during the 16-week at the week 16, and you can see that peripheral vascular resistance was reduced much more with the combination treatment vice separate treatment of both drugs. If we have a secondary endpoint, the result was not so, as we were expected to be, because with the 6-minute walking distance expressed in meters, we see that we were having almost statistical significant difference in between combination group, vice group with tadalafil, but the first result with pulmonary vascular resistance was really nice. As for the adverse drug effects, to cut a long story short, this clinical trial showed that combination treatment was similar in adverse drug reactions comparing to the separate components. And the results was published in very nice paper. There is a DOI number here, so you can read it, where the authors are concluding that there was a marked hemodynamic improvement in the macitentan tadalafil fixed dose combination arms, if we are talking about the drop of pulmonary vascular resistance, and this combination was very well tolerated because safety profile was consistent with macitentan and tadalafil. Two more drugs were very important for approving the final combination for the FDA approval, and this is a Triton and repair studies. In this study, we were comparing data from patients from 2 studies on initial macitentan and tadalafil double combination therapy, and 2 subgroups defined as patients without cardiac comorbidities and those with 1 or 2 cardiac comorbidities. Why? We know that pulmonary arterial hypertension advances to heart failure. And this study was designed to show us if there is any usefulness in using drug at the beginning after the diagnostic process was done, whether there were present or absent some cardiovascular morbidities. Triton was a multi-center, double-blind, randomized phase 3 study, and patients were treated with either initial triple oral therapy showed here or initial double oral therapy. Repair was another study, multi-center, single-arm, open label, and in this study, patients in repair were treated with macitentan with physicians having the option to additionally initiate a phosphodiesterase 5 inhibitor within 14 days. The main result was that we had patients with pulmonary arterial hypertension receiving macitentan and tadalafil as initial combination showed that the results were comparable in between the groups according to decrease of pulmonary vascular resistance and the 6-minute walking distance increase, also with the functional capacity improvement and so forth. So initial double combination therapy with macitentan plus tadalafil was efficient in patients with pulmonary arterial hypertension with up to 2 cardiac comorbidities, and safety was similar for patients with and without cardiac comorbidities and consistent with known profiles of both drugs. And the third key point study was also a study comparing 2 already finished studies, Opus and Orpheus. And what was the point? Historically, patients recently diagnosed with pulmonary arterial hypertension have had a poorer survival than those with a longer time from PAH diagnosis, and we are calling the first group of patient incident and prevalent. We wanted to see, but the authors wanted to see if the survival of patients that are initially diagnosed but didn't receive the therapy would be increased if the therapy is initiated immediately. So despite guideline recommendations for initial combination therapy for most patients with pulmonary arterial hypertension, many are initiated and maintained on monotherapy. And real-world evidence to evaluate the benefit of early combination treatment in new diagnosed patients was lacking. So this drug was shown with the main purpose to describe the demographics, clinical characteristics, safety and tolerability profile, and outcomes for patients with pulmonary arterial hypertension initiating macitentan and tadalafil combination therapy by time from diagnosis. And this is a Kaplan-Meier curves estimating the time from macitentan plus tadalafil combination initiation to first all-causes hospitalization. What was clear as a conclusion that the incident patients, including those with initial combination therapy, had similar survival, time to first all-cause hospitalization, and safety tolerability profiles to prevalent patients, supporting the use of early combination therapy with this combination. So we can see the survival results, hospitalization-free results, and persisting on combination after the study was already performed. Safety was similar for all cohorts and consistent with known profiles of macitentan and tadalafil. Let's go to explain the pharmacodynamics or the mechanism of action. So it's very simple. I was, as an experimentator, doing lots of experiments of isolated blood vessels with different vasoactive substances and examining whether endothelial cells and endothelial relaxing and contracting factors were included. So you can see that endothelin-1 is going to be produced from the big endothelin-1 through the converting specific converting enzyme and released to produce some effects on smooth muscle cells, but also on endothelial cells, usually through the ETB receptors. What is important for this slide is that macitentan is non-selective endothelin receptor antagonist, producing the anti-vasoconstriction effect, so reducing the pulmonary arterial hypertension. On the right side, you can see that tadalafil as a phosphodiesterase inhibitor has several points of action because this enzyme is present in different tissues, in pulmonary circulation, in heart, in systemic circulation. So it is not surprising that tadalafil produce a decrease of medial pulmonary arterial pressure, then decrease the right ventricular pressure, that reducing the enlargement of right ventriculum, and also having effect on the final right ventricular failure, because in the heart there is lots of phosphodiesterase during the pathological process. So you can see that tadalafil is having a little bit more complicated mechanism of action than endothelin receptor blockers. As for the pharmacokinetics, so I was mentioning several times that the fixed dose combination was shown to be comparable to the specific drugs that are in this combination. But this paper was very nice, showing the bioequivalence and the food effect of macitentan tadalafil combination versus the use of single component tablets in the healthy subjects, and the results were quite nice. That the study demonstrated complete bioequivalence, so this is really nice, between the fixed dose combination of macitentan tadalafil in a single tablet and the free combination of both drugs in healthy participants, and that this fixed dose combination can be taken without regard to food, similarly again to the individual components. And this fixed dose combination was generally safe and well tolerated. However, there are quite lots of specific special warnings and precautions, and this is quite another story, separate maybe from this lecture. That's why I'm giving you just a clue what to find out tomorrow reading about this drug. There were some there are some very nice evidences that hepatotoxicity, hypotension, hemoglobin decrease, worsening of pulmonary vein occlusive disease, visual loss with the retinal impairment, hearing impairment, fluid retention with the edema, and so on and so forth is very important when prescribing this drug. So this drug is not for each and every patient, especially if you remember this warning red box from the beginning of this lecture. However, some quite specific contraindications are pregnancy, hypersensitivity, concomitant use of organ nitrates, I will explain, and concomitant use of guanylate cyclase stimulators. Why? Because we can have lots of interactions with the strong cytochrome microsomal enzyme system inducers and inhibitors. And on the next slide, we're going to show them what's going on with these interactions. So nitrates are donors of nitric oxide. And if you have another drug, producing the similar effect and moreover used for the erectile dysfunction like tadalafil, so the administration within 48 hours is contraindicated. With the strong cytochrome enzyme system inducers like rifampin, we can say that rifampin can reduce macitentan exposure because it will increase the metabolism and reduce the macitentan active concentration. Conversely, strong cytochrome enzymes inhibitors like ritonavir used in HIV infection, ketoconazole and itraconazole used in fungal infection, increases exposure to both macitentan and tadalafil. Alpha blockers used in hypertension, they are producing hypotensive effect by blocking of alpha-1 receptors on smooth muscle cells. And if you add phosphodiesterase 5 inhibitors, you're going to obtain lowering pressure, even very strong hypotension. As for the alcohol, substantial alcohol in combination with the combination drug, it increased the potential for orthostatic signs and symptoms. Please remember that ethanol is having several order of kinetics. So in a smaller concentration in our circulation, this is the first order kinetic when the metabolism is proportional to the alcohol introduced to our metabolic system. However, the enzymes degrading, which are including degradation of alcohol, are not present as much as we want them to be. So there is a saturation. And then you have the zero order kinetics, in which toxic alcohol products can be identified in the larger concentration. As for the adverse drug reactions, the most frequently reported adverse drug reaction of the combination, not of the separate compounds, is the edema and fluid retention and anemia and headache. This is a new drug. It is registered last year in 2024. So we don't have so much information from the post-marketing surveillance, because that adverse drug reaction reporting is something that each and every physician should do. However, it is not like that in the everyday practice. So we can say that additional adverse reactions have been identified during the post-approval use of tadalafil, because these reactions are reported voluntarily from a population of uncertain size. It is generally not possible to reliably estimate their frequency or establish a causal relationship to drug exposure. So you have, that you have a stepwise approach in establishing a causal relationship to drug exposure. So for the macitentan, as expected, liver injury, hypotension, hypersensitivity reactions. As for the tadalafil, we have some cerebrovascular and cardiovascular and cerebrovascular events, but they are expected if we are talking about the basic mechanism of action, like myocardial infarction, sudden cardiac death, strokes, and so on. We have some unwanted effect at the level of nervous system, some hypersensitivity reaction, and then I'm stressing out again for the tadalafil. Visual field defect, retinal vascular occlusion, sudden hearing loss. These are all red lights to discontinue therapy at that point. So we don't have an antidote for the overdosing, and the start and supportive measures should be taken as required. Dialysis is not useful because this combination is, especially macitentan, is highly bound to the proteins. And you can see that in this slide we have the highest doses that were tested in the first phases and luckily without death outcome. What are the current perspectives? Well, they are great. So people are quite interested for further investigating of this drug. And you can see only 3 studies here that are in this recruiting phase. So I will just tell you briefly about this first one, because this is an important one for the follow-up protocols. And the purpose of this study was to enable participants with pulmonary arterial hypertension currently treated with study intervention in a clinical study to continue the benefit from the intervention after closure of the parent studies in case they have no alternative means of access to the study intervention. And this study will allow assessment the long-term safety of each study information intervention. And this is very important because usually after the clinical trial stops, some part of patients may stay without needed drug. And this is why this is very, very important study in my opinion, because we have some very nice primary outcome measures: frequency of treatment emergent adverse effects, frequency of treatment emergent adverse effects to discontinuation of treatment, frequency of serious adverse effects, and if any, frequency of death outcomes. So you see the intervention treatment. We are going to use Macitentan, we are going to use Selexipag, and of course we are going to use our fixed dose combination 10/40 milligrams of Macitentan and tadalafil once daily during the course of study. Instead of conclusion, one very nice, wonderful, and well-put sentence of Professor Kelly Chin. As administration of Macitentan and tadalafil together are commonly prescribed for initial therapy of pulmonary arterial hypertension, the introduction of a single tablet combining both is promising for clinicians treating patients, as it may help bridge the gap between clinical guidelines and everyday clinical practice, while offering a patient-friendly approach to support initial combination therapy and rapid escalation for the appropriate patients. So this sentence tells everything. Thank you very much for your kind attention. For more information, please follow my ResearchGate account and write me for some possible cooperation. I would be very happy to cooperate further in the future with you. Thank you very much.